Okay, so this starts us with our next topic, that is anemias. Anemia, you very well know, it is reduction in total circulating red cell mass. It is reduction in total circulating red cell mass, below normal limits, below the normal limits. This is just a fancy way of saying that the red cell mass has reduced, hemoglobin has reduced. So the hemoglobin cutoff for anemia will be patient dependent. That is, I can safely say in case of adult males, all these values, they are from physio, you know them. Adult males less than 13 grams per deciliter, less than 13 grams per deciliter is considered as anemia, versus adult females, females physiologically have a lesser normal hemoglobin than males. So in females less than 12 grams per deciliter. Pregnant females or pregnancy, it is physiologically also associated with delusional anemias. So here the cutoff is further reduced for hemoglobin less than 11 grams per deciliter. Next point, at birth, the cutoff for anemia is again 11 versus infants, where it is less than 10.5 grams per deciliter. So nothing major, just go through this once and you will be comfortable with this. Males 13, females 12, pregnancy 11, birth 11, infants 10.5. So firstly, this starts us with our first topic, that is classification of anemia. On the basis of size of the RBC. Classification of anemia on the basis of size. I can classify anemia into three types on the basis of size, which is MCHC, that is microcytic hypochromic anemia. MCHC, microcytic hypochromic. NCNC, that is normocytic normochromic. And the last is macrocytic anemias. Let's see this on the basis of size. RBC can either be smaller than normal, microcytic, normal size, normocytic, larger in size, macrocytic. Microcytic hypochromic, normocytic normochromic, macrocytic. What do we mean by this? MCHC, microcytic hypochromic. Microcytic means the size is smaller. Hypochromic means central pallor of the RBC is more than 1/3 the volume of the RBC. See, you very well know that normally RBCs have central 1/3 pallor. This is a normal RBC. Normally they have central 1/3 pallor. This is normal. If the central pallor is more than 1/3, it is called as hypochromic. So microcytic, smaller RBC with central pallor more than 1/3. Microcytic hypochromic, normocytic normochromic, macrocytic. First point, starting with MCHC, microcytic hypochromic RBC, the causes of MCHC, diseases associated. Which is the most common cause of microcytic hypochromic anemia? Iron deficiency anemia, IDA, that is iron deficiency anemia, IDA. Other causes of microcytic hypochromic anemia are thalassemia, sideroblastic anemia, sideroblastic anemia, and anemia of chronic disease, and ACD, anemia of chronic disease. A very basic list. Causes of MCHC, microcytic hypochromic anemia. See, I resigned from my AP post, assistant professor post in AIIMS around 1.5 years ago. I never believed in flunking any student, but for the second years, this was my last question, in the sense that, Bache, please tell me the causes of MCHC, otherwise I won't be able to help you. So MCHC, a standard list: iron deficiency anemia, thalassemia, sideroblastic anemia, anemia of chronic disease. Most common cause of microcytic hypochromic anemia being IDA. Next point. Let us see this here only. Most common cause of anemia. Next point. Most common cause of anemia in hospitalized patients. Most common cause of anemia in hospitalized patients. Answer. Normally in my live classes, sometimes I hear the answer as IDA. Nahi bache, we do not hospitalize a patient of iron deficiency anemia. We give him a tablet and send him home. It's an OPD basis treatment. Most common cause of anemia in hospitalized patients, ACD, anemia of chronic disease, ACD. Next point, most common type of anemia. Next point, most common type of anemia in ACD. Most common type of anemia in ACD: microcytic hypochromic, normocytic normochromic, या macrocytic? Normocytic normochromic. Please put a star on this. Most commonly ACD causes normocytic normochromic anemia. Rarely it is microcytic hypochromic, but rarely it can cause MCHC, so it is one of the causes of MCHC. So first point, the first way to classify anemia on the basis of size of the RBC is microcytic hypochromic. Next is normocytic normochromic. NCNC, normocytic normochromic. Normocytic normochromic anemias on the basis of retic count. So let me make this table again. There were three ways to classify on the size: microcytic hypochromic, normocytic normochromic, and macrocytic. This was our table. Normocytic normochromic anemia on the basis of retic count, is divided into low versus high retic count. Retic count we just saw in the previous topic, that is the basics of RBCs. It was the immature RBCs in peripheral smear. We saw low retic count. The causes were, it is the same list. Low retic count. The causes are aplastic anemia. Next, keep on speaking. Next, myelofibrosis, CKD, chronic kidney disease. This is the same copy paste list which we saw in the previous topic. Chronic kidney disease. Next, nutritional anemias. Should I write nutritional anemia here? No. Nutritional anemias are iron deficiency anemia and megaloblastic. Iron deficiency anemia is microcytic hypochromic. Megaloblastic is macrocytic in nature. So I will not write nutritional anemias. The last is ACD, anemia of chronic disease, versus high retic count, which is associated with hemolytic anemias. So this is the same list, normocytic normochromic anemia. We divided it on the basis of retic count, low versus high. Just nutritional anemias is not there in this list. And lastly, the last is macrocytic anemias. They are further of two types, that is megaloblastic anemia that is megaloblastic anemia and non-megaloblastic. Sorry, we'll do this in detail when we study nutritional anemias. So macrocytic, they are of two types, megaloblastic, non-megaloblastic. You very well know folic acid and B12 deficiency. Folic acid and vitamin B12 deficiency is megaloblastic versus liver diseases, which is non-megaloblastic in nature. So we divided macrocytic anemias into two types, megaloblastic and non-megaloblastic. This is classification of anemia on the basis of size of the RBC. Classification on the basis of size. Next point. This gets us to classification of anemia. This gets us to classification of anemia on the basis of etiology. On the basis of etiology. Etiology means cause of anemia. We can divide the anemia on the basis of cause again into three types. That is blood loss. Next, increased destruction of RBCs. And lastly, reduced production of RBCs. So, classification on the basis of etiology. Blood loss, increased destruction, reduced production. Increased destruction of RBCs is called as hemolytic anemias. Increased destruction is called as hemolytic anemias. We will do each one of these one by one. Starting with, we are just writing the classification, so just let us write down the diseases. Hemolytic anemia. Let us start with this. Most common RBC membrane defect. Answer bache. Most common RBC membrane defect. HS. That is hereditary spherocytosis. Most common RBC membrane defect. HS. Hereditary spherocytosis. Next, most common RBC enzyme deficiency. Everybody knows this. Most common RBC enzyme deficiency. G6PD deficiency. Glucose 6-phosphate dehydrogenase. G6PD. Glucose 6-phosphate dehydrogenase deficiency. G6PD deficiency. Next is hemoglobinopathies. Hemoglobinopathies. There are two, that is sickle cell anemia. Hemoglobinopathies, which are sickle cell anemia, HbS, sickle cell anemia, and thalassemia. Hemoglobinopathies. Next is PNH. That is paroxysmal nocturnal hemoglobinuria. PNH, paroxysmal nocturnal hemoglobinuria. Paroxysmal, kabhi, intermittently. Nocturnal, at night, there is hemoglobinuria. Paroxysmal nocturnal hemoglobinuria. And the last is AIHA. That is autoimmune hemolytic anemia. AIHA, autoimmune hemolytic anemia. So, hemolytic anemias. 6 main ones. Most common RBC membrane defect, hereditary spherocytosis. Enzyme deficiency, G6PD deficiency. Hemoglobinopathies, there are two, sickle cell anemia, thalassemia. Next is PNH and AIHA. These are the hemolytic anemias. Before we go further, let us write down the inheritance pattern associated with these. HS, hereditary spherocytosis. Inheritance, we write it as capital HS, autosomal dominant. It is the same thing we saw in general path genetics. HS, autosomal dominant. G6PD deficiency, answer bache. Which are the 4 Mendelian inheritances? Autosomal recessive, autosomal dominant, X-linked recessive, X-linked dominant. G6PD deficiency, X-linked recessive. X-linked recessive. Next, both the hemoglobinopathies, sickle cell anemia and thalassemia, autosomal recessive. See, easy to remember. Capital HS is hereditary spherocytosis, autosomal dominant, versus the hemoglobinopathies, HB small s, autosomal recessive. Next, PNH and AIHA, inheritance pattern. Inheritance, they are acquired in nature. They are acquired in nature. We cannot blame our parents for everything. These PNH and AIHA, they are not hereditary disorders. They are acquired in nature. These are the hemolytic anemias, the main ones. And the last category is reduced production of RBCs. If the production of RBCs is reduced, it means the patient has a reduced retic count. Reduced production is associated with a reduced retic count. So diseases with reduced retic count. This is the third time we are making this table. Answer, aplastic anemia. Aplastic anemia, chronic kidney disease, myelofibrosis. Aplastic anemia, chronic kidney disease, myelofibrosis. Nutritional anemias, and anemia of chronic disease. Nutritional anemias and anemia of chronic disease. Sorry. So this is classification of anemia on the basis of etiology. Blood loss, increased destruction and reduced production. Whatever we have written on this slide, we will do this one by one. This is your topic, RBC disorders. So starting with the first and the smallest one, let us see this here only, blood loss. This starts us with the first component, that is blood loss. Blood loss. Causes, very obvious. It is associated with acute blood loss, that is trauma. Acute blood loss associated with trauma versus chronic blood loss, which would be associated with GIT lesions or adenocarcinomas. Suppose a patient is suffering from adenocarcinoma of the GIT. That in turn would lead to bleeding leading to blood loss or anemia. GIT lesions or adenocarcinoma or gynecological abnormalities. Next, in cases of blood loss, if there is an acute blood loss, the body tries to compensate, as a result of which retic count increases, or let me rephrase this as reticulocytosis. Retic count increases matlab reticulocytosis. It starts on day 5 and peaks at day 7. Reticulocytosis. After acute blood loss, the body is trying to compensate for the same. So reticulocytosis, it starts at day 5 and peaks at day 7. How much? Approximately 10 to 15%. Approximately 10 to 15%. Next point. There is also an increase in MCV. there is also an increase in mean cell volume because of reticulocytes, because of reticulocytosis. Reticulocytes were the immature RBCs which were present in peripheral blood. Immature RBCs will have a higher volume, so it is associated with increased MCV. And early recovery is also associated with thrombocytosis. It is also associated with increased number of platelets or thrombocytosis. This was your smallest topic, that is blood loss. So what we saw in this was classification of anemia on the basis of size and etiology. Next, so let us take a break at this point and we start with our next topic and the main one, that is hemolytic anemias. We will do each one of these hemolytic anemias in detail one by one.